It's a pleasure to be here. I hope I can give you some clues about how to approach the problem of dysphonia. I'm using the term dysphonia. A lot of you might think in terms of hoarseness, but hoarseness is not necessarily dysphonia. It is a kind of dysphonia, but dysphonia is just an abnormal way of producing your voice. And a hoarse voice is only one feature of what could be a dysphonic patient. So today I'm just going to run through a clinical description, how we describe a person's voice for our own benefit, to give us clarity of thinking about what the voice is all about. And I might add that many of the things, I'm not going to show you videos of the larynx today because you people are not at this stage generally able to examine the larynx and make a decision about it. This is something you hear, not what you see. You've seen some lovely videos today, and again, some of them are not sort of thing that you're going to experience, but it's nice to have insight. I was talking to David Grayson. He's very innovative, as you can tell, and he is talking to me about a disposable endoscope that you could use relatively cheaply, single-use item, and examine the larynx and pharynx in your rooms in the community. So that's a plan. And I think that's very exciting. So next year, if we talk this again, I might have to show a lot of videos. I'm going to describe what you hear, and I'm going to then talk about the factors that contribute to a voice being abnormal and being produced abnormally. And then I want to just give you a little aid memoir that might help you think about how to think about managing a patient or treating a patient's risk factors. Also, I identify the red flags that you need to know in order to be alert for a significant pathology that needs to be reviewed in the secondary or tertiary level. And so in that process, I'm going to give you what I think is maybe a helpful guide to refer the patient on. So the description. Now, how am I going to do this? Because it's not moving. There we are. I'll do it this way. So we have this acronym called GRABAT, and that stands for grade, roughness, breathiness, asthenia, it's a weak voice, and strain. And you can hear these features every time your partner comes home from after a day at work. You will know how that person is feeling by what you hear in the sound, in the voice, especially in respect of roughness and strain. And breathiness maybe is something else and completely, it's not shortness of breath, it's a breathy voice, escape of air in the process of phonating. And we grade it according to whether we think that feature is normal or slightly abnormal, moderately abnormal, or to a high degree affected. And so the sort of thing that we might see or score is a patient have a grade 2 voice, which is moderately affected in respect of roughness, no breathiness, no asthenia, not a weak voice, but a bit of strain. And that's something that we use as a comparator for the next time we see them to see how they're progressing. The patient, of course, also rates their own voicing using a voice handicap index, which I'm not going to go into today. And you don't have to know all of this. I think if you can just grade the patient's voice, if you want to refer a patient on, it's really helpful for us to know what severity of the voice is. When we get referrals for voice problems, almost never do I see anyone saying anything about how severely the voice is affected. And it would be really helpful to know if you think it's a grade 3 voice. The risk factors for dysphonia I classify into recreational, occupational, medical, or intrinsic. Intrinsic being the patient doing it themselves. I'll kind of cover each of these things, but the guiding principle you should be thinking about, or at least I believe you should be thinking about, is the voicing, abnormal voicing, constantly there, or is it intermittent? Is it sometimes normal and sometimes bad? Or is it always bad, but sometimes worse than others? That's a big difference. If they can revert to normal, then it helps you determine whether or not the probability of the voicing problem is going to be structural or functional. If in fact they get a normal voicing and then it goes bad, then it's more likely to be functional. If it's an abnormal voicing that's constantly abnormal to some degree or another, then it's almost certainly, it's more likely at least to be a structural problem, either a papilloma or a polyp or edema or a nodule or something like that that's permanently abnormal and creating a distortion of the vocal folds when they come together to vibrate and phonate. So keep that in mind. Is this and it would be really helpful to know if this person has been constantly hoarse or intermittently hoarse. If it's intermittently hoarse, it's the way they're using their voice. They get strained or stressed or that sort of thing. And then when the precipitating factors have gone, then the voicing is back to normal again. There's been no structural change to the laryngeal tissues. And I like to think of this as a member, the xerostomach, obese, addicted, allergic auctioneer with a woodworking hobby and a seriously unwell family at home. And this might help you focus on how you might manage the patient. Because if he's xerostomach, everything's going to be dry. It's like having no oil in your gearbox, and things are not going to work so well. So, and this could be as a result of medication, and antihistamines were mentioned earlier this afternoon or this morning. They dry people out, and if you've got no lubrication in your larynx, then it's going to be more difficult to have a nice, smooth voicing process. People who have autoimmune conditions like Sjogren's and rheumatoid arthritis, that sort of thing, may also be dry and xerostomach. And the treatment for xerostomia in this situation is to give them, to tell them to have warm water, but start off with hot water and just breathe the steam through an open mouth. And the steam will just coat the larynx and pharynx and it settles things down. And they can do that all the way through the day. They don't have to drink the hot drinks, but they can use hot drinks for steam. If they're obese, then they're likely to have reflux, and they've got poor breathing technique, and the breathing is the driver for the voice. If they're addicted, they've got tobacco and alcohol, and those are things that you should be able to manage, at least, or advise the patients about behaviour. Allergic, well, that's where you have asthmatic patients who are taking puffers, and that can be quite irritant to the larynx. Sometimes the particles, and certainly the steroids that you inhale, can impact on the larynx and affect the voicing. So you need to be aware of that. And if they've got rhinosinusitis as a result of allergy, it doesn't have to be allergy, then they often have mucus, they've got a cough and they're clearing their throat a lot, that sort of thing. They also clear their throat a lot with reflux, of course. So these things are all aggravating the larynx. If you've got asthma, then you've probably got a poor breathing technique as well. And Jim has already talked to you a lot about the breathing. People come in with voicing problems, and they're doing this all the time. They may not have pain, but they've got muscle tightness in the upper chest and in the neighbouring muscles of the neck, and they get this muscular tension, dysphonia. And of course, if he's an auctioneer, it doesn't have to be an auctioneer. It could be a teacher. It could be a lecturer. It could be anyone who's speaking to large numbers or speaking on the telephone, being a receptionist. Then these people may have a degree of voice misuse. They haven't got a good technique of voicing. I say to these people, you pick up a pen and write your name, and that's your signature. Then you hold the pen really tight and do it again, and it doesn't come out the same. And that's effectively what many of these people are doing with their larynx. They've tightened up, and then the voicing is distorted. Of course, environmental irritants could be social, could be recreational, or could be occupational. And think of that. And a seriously unwell family, that's a biggie. It's an indicator. Think of that. Think of stress. It may not be. They may not come in and tell you about the things that are happening at home, but that can be a big feature. And so I'll put a circle around the big ones that you need to try to remember every time you see someone with a voicing problem is think about reflux, think about their breathing techniques, think about tobacco, think about their occupation, what sort of work are they doing, and think about stress. And you can actually impact on all of those things with your advice and management of that patient and telling them how to go. The red flags are the big deal. Dysphagia to solids, you ask the patient, does the food stick? And if the food sticks, for me, that means there's something stopping it, and it could well be a carcinoma in the larynx or pharynx. Dysphagia to liquids, that's when you cough when you swallow. And that's often because poor movement in the vocal folds. And these people are often got a breathy voice because the vocal folds are not coming together. And so the larynx is open when they're drinking, but it's also open when they're talking. It's not very helpful. Earache is a really bad warning for me. If people get earache and they've got dysphonia, then you have to worry about some neural infiltration in the nerves of the larynx, and with referred pain to the ear, because the vagus nerve goes to the larynx, but it also goes to the ear. And it's often a bad sign if they've got earache. A large cervical lymph node speaks for itself, really. You don't want to see those, but you've got to examine for them. And bloodstained sputum production, it's worth asking about that. And again, that's a red flag. Stridor, of course, it's obvious that they've come in and you can hear them breathing. So when do you refer them? Well, any of those red flags. You don't have to have them all. In fact, any one of them is enough to lead you to say, I must refer this patient on, and quickly, and identify that in the letter, and you'll be sure to get a very quick response. If you've got someone with a total loss of voice, can't talk. This is quite often a conversion reaction, often occurs in young women, and get onto that quickly, contact the voice therapist and say, this person has been unable to phonate at all for the last 5 days. And they can be that problem can be unloaded very quickly by a speech language therapist. So I would say if you've got a referring patient, if you're referring a patient with total loss of voice for a week or more, then you really ought to get them into the voice therapist. Constant dysphonia for more than 2 weeks, I think, is, again, that's that first key question. Is it constant or is it fluctuating? And intermittent dysphonia for more than 6 weeks that's unresponsive to the management plans you put in place should be referred through. So in summary, the priority is to look for the red flags and refer the patient. Note that it's like, who said this? Zahor said, you know, what hasn't changed is history and examination. You can't examine the larynx, but you can listen to it. And you've got to ask the progress and the nature of the dysphonia and management, and then manage the risk factors that you can identify and refer patients with persistent or progressive dysphonia.